Hi there, welcome to my YouTube channel and our ongoing discussions about psychiatric disorders. Today we're going to talk about obsessive compulsive disorder. Now, this is not, contrary to popular belief, technically an anxiety disorder, which is unfortunate really, because in the old DSM-4 iteration, it was grouped in with the anxiety disorders. And I actually think that that was a sensible lumping together, because my patients will tell me that their obsessions and compulsions cause them anxiety. However, in the new DSM-5, this is the desk reference, but you can get in the full textbook if you wish, it is lumped in together with the related disorders such as trichotillomania, where people are pulling their hair out, excoriation disorder, where they're scratching themselves, skin picking disorder, hoarding disorder, and what we call body dysmorphic disorder, which is also known as imagined ugliness. They're very much obsessed with certain parts of their appearance and how others would view them, and they view their nose or their ears or parts of themselves as objectionable and ugly and requiring treatment or reconstructive surgery. There's an obsessive or repetitiveness, which is a common theme to all these disorders. Now, part of the reason why they were kind of delineated from the anxiety disorders is partly because we now know that the biology of this is related to a part of the brain called the orbitofrontal cortex, which is in the front part of the brain called the prefrontal cortex, where one plans, executes, decides, sequences, whereas the anxiety disorders are more related to a more primitive part of the brain called the amygdala, which is a kind of a signal alert to danger, whereby the stress hormones such as adrenaline or noradrenaline are released and result in flight or fright and being very overwhelmed suddenly. I think that's unfortunate because my patients have told me that they feel extremely anxious with their obsessions and compulsions. But let's talk about the symptomatology as is broadly defined. Obsessions are the mental phenomena and compulsions are the associated behavioral way of coping, so to speak. So obsessions typically are one's own thoughts, but they tend to be intrusive and of a nature that is very unpleasant, with themes such as sexualized themes or obsessions about dirt or unpleasant, horrible things that are happening. The classic example is given is that of a very religious person, law-abiding person sitting in church with thoughts of their loved ones suddenly dying in a car crash. Obviously they're very unpleasant and they'll make the person wince, and many a time people will fight those thoughts, try to suppress those thoughts, argue with those thoughts, which tends to make them worse, kind of reinforces them. Now, sometimes people have mental rituals. You could think of these as the mental equivalent of compulsions. Now, compulsions are physical behaviors, but mental rituals, which are really kind of idiosyncratic, absurd, odd, very senseless ways of responding that somehow give the person relief in that moment. So they maybe count to 10, or they'll rehearse a certain answer in order to cope with it. And that's kind of built up over time. Unfortunately, that in itself tends to reinforce the obsession in the first place. Other time, and this is more familiar to many people, they'll do things like tapping a certain number of times or sidestepping cracks in the pavement, having to go back a number of times to make sure the door is locked. That's called obsessional doubt, leading to kind of repetitive checking. So there's a way of reassuring oneself which is not particularly helpful, but somehow in the moment seems to relieve the anxiety. And when I ask my patients, well, why do you respond in that way? They'll say that, well, if they don't, their anxiety will grow, and that itself becomes unpleasant and difficult to deal with, but it's reinforcing. So these are the manifestations of obsessive compulsive disorder. There's a repetitive aspect to it, there's a rigidity, there's a stylized, ritualistic, repetitive, we call perseverative, doing things past the point of reference. So for example, checking 100 times, 20 times, scratching to the point where you're bleeding. I mean, it's excessive, it's unreasonable, it's senseless. And the person recognizes this at some level. Sometimes over time, it may almost become such a habit that it's no longer senseless to them. So the degree of insight may change over time, whereby the insight lessens and lessens as the behaviors take over. And this is where some have argued that this has become frankly delusional. And that's an academic discussion, but in the beginning certainly the person recognizes this as very anxiety provoking, very disturbing, very intrusive, and something that has to be dealt with in a repetitive way. Now, the standard treatment for the obsessive compulsive disorders is higher doses of the SSRIs, things like Paxil, Prozac, Zoloft, Lexapro. We've talked about these medications before. I tend to use a medication called Luvox. Now that is known as Fluvoxamine, and that is actually FDA approved for obsessive compulsive disorders, but as are others. And it's not that that in itself is the best medication. I don't want to give that impression. What I do want to say is that it is one of the more potent serotonin reuptake inhibitors, and I've had a lot of success, like as many other psychiatrists have, with prescribing this particular medication. But again, it has to be dosed appropriately and typically in higher doses. The dose of, for example, Prozac that we would use in OCD would typically be about 3 or 4 times higher, about 60 to 80 milligrams compared to say 10 to 20 milligrams for generalized anxiety disorder. Now that's, again, not a rigid kind of rule. It depends on the patient, depends on their tolerance, but you would want to see higher doses prescribed. That's certainly what the practice guidelines recommend. For Fluvoxamine, I usually start with a dose of 25 milligrams, and it can go all the way up to 300 milligrams. And sometimes we have to augment it. We talked about augmentation strategies in the past, whereby if you've maxed out something, you want to add on something. So, there are lots of options available for those who are maxed out on certain obsessive compulsive disorder medication. But I want to emphasize that we have to have higher doses. And as before, I want to emphasize that we also must combine this with psychological therapies. Typically, in the case of obsessive compulsive disorder, we would do what we call habit reversal, which is basically delaying the urge to respond to a compulsion, such that the time from the obsession to the compulsion is longer and longer and longer. And that's our yardstick for success, actually. The frequency, intensity, intrusivity, the degree of distress, and the degree of, I wouldn't say control, but the degree of mastery one can achieve in not yielding to compulsions, which, of course, as we've said before, are paradoxically reinforcing. So we will combine those two, no surprise to those who've seen this channel before, we combine these approaches in order to have the most effective outcome. Now, there are other forms of obsessive compulsive disorder which are, and this is in children, for example, related to having a strep infection, and that's called PANDAS. PANDAS is the acronym related to autoimmune system antibodies that somehow lead to kind of very repetitive behaviors and related to streptococcal infection. And again, this is a rarer form of OCD, but it does respond to antibiotics as opposed to the SSRIs. Still, other movement disorders have an obsessive aspect to them and can respond to dopamine blockers. So, for example, Huntington's chorea, etc., are thought to have a certain repetitiveness to them. So this is where, as something becomes more and more of a movement disorder, even from a compulsion, these descriptions become less and less rigid and more debated as to what they're describing phenomenologically. And I don't want to overwhelm you with academic discussions of that nature. I want to confine this to OCD. But I would use the same higher doses for things like body dysmorphic disorder, for hoarding disorder, where someone is collecting newspapers or belongings or whatever to the point where the room is filled and having to use storage. It's very upsetting to family members that this is just accumulating and unnecessary and absurd. So we would tend to have the same approaches for those disorders. Same thing for skin picking, trichotillomania. We would again have the same approach. So I want to show you how related these disorders are phenomenologically and even biologically, and pharmacologically the approaches are the same as are psychologically. You want to have someone yield less to this urge to complete, the sens d'incomplétude, as is oftentimes described by phenomenologists of old. Now, I have heard people say in common speak, oh, I have OCD tendencies. I want to take this time to distinguish obsessive compulsive disorder from obsessive compulsive personality traits and obsessive compulsive personality disorder. And I say that because I think the public bandies around terms such as this without realizing the distinctions. Obsessive compulsive personality and disorder are very much related to a certain rigid, inflexible personality that sees the world in a certain way. They can be very kind of judgmental, rigid, high moral values. They have to see things a certain way. They don't see things another way. It's kind of my way or the highway. They're very detail-oriented and they won't start a task until they go all the way. They're kind of perfectionistic and they find it hard to enjoy themselves. Leisure for them is something that has to be an achievement. It has to be a performance, and it has to be perfect. You can see how that's a different flavor to obsessive compulsive disorder, where you have these intrusive obsessions and compulsions that are very distressing and that the person wants to get rid of. obsessive compulsive personality disorders oftentimes don't see themselves as pathological. They view that their way of doing things is the right way to do things. But because of their overly detailed obsession, their very, very heavy emphasis on the perfection, others will notice it, and it will lead to interpersonal difficulties, conflicts. Sometimes people are even fired from work because they're just simply too detail-oriented and inflexible and unable to see others' point of view and not really team players. So when people talk about OCD tendencies, I think that's become a public vernacular that really has no meaning. What they're probably referring to is people who likely have obsessive compulsive traits, and when accentuated, it can become a disorder. This is sometimes comorbid with, or sometimes not comorbid with, obsessive compulsive disorder. Funnily enough, I've found that if I'm giving Luvox or an SSRI to treat OCD, which may happen to be comorbid with, coexistent with obsessive compulsive personality disorder, I found it kind of shaves off the rigid edges, the inflexibility, the overly detailed orientedness. Because maybe at a biological level, the brain doesn't care about our labels. We care. We revise these labels every 7 years by consensus and committees, because we're trying to describe a phenomenon. But from the brain's perspective, biologically, they may be more related than one thinks. And the SSRIs I found have had some utility in at least reducing the extent of inflexibility, rigidness, detail-orientedness. And so that's an anecdotal experience I can share with you as a practicing treating psychiatrist that may help people when they talk about, do I have OCD? Do I have OCD tendencies? You have to take a careful history, as I've said all along in this channel, to distinguish between different phenomena. But I hope this is helpful, and we will go on to talk about other psychiatric disorders. As before, I want to thank you for your support of the channel. I welcome your comments and feedbacks. Otherwise, stay healthy, and I'll see you in the next video.